Hello everyone, we are from Group 6. Our group members is Jing, Yee Qi A202507, and Alif Farhan. Today we're going to talk about patient-centered approach for Parkinson disease.
Today, I'll be talking about a neurological condition that affects millions worldwide, which is Parkinson's disease. Parkinson's disease is a progressive brain disorder that affects movement, leading to symptoms such as tremor, muscle stiffness, and slowness of movement. It happens because of the loss of dopamine producing neurons in a part of the brain called the substantia nigra. As the disease progresses, it not only affects physical movement but also has emotional and psychological impacts, making treatment more than just a medical task. This brings us to an important approach in modern healthcare. To truly care for someone with Parkinson's disease or any chronic condition, we must just go beyond treating the disease and start caring for the person. This is where the patient centered care approach comes in. Patient centered care is a model that places the patient's values, needs, and the preferences at the heart of every decision. Instead of asking, "What's the matter with you?" we ask, "What matters to you?" It's about building partnerships between patients and healthcare professionals aiming for better satisfaction and better outcome. There are four key principles that guide this approach. Number one, understand the whole person. We care for the patient's body, mind, emotion, social needs, and respect their background and lifestyle. Number two, we listen to their story. We don't just treat symptoms, we listen to how the illness affects their life. Number three, shared decision making. Patients are encouraged to be involved in their own care, their own voice matters in every clinical choice. Number four, set meaningful goals. Care is personalized. We focus on goals that help the patient live the life they want. When caring for someone with Parkinson's disease or any long term condition, this approach helps them feel heard, respected, and empowered. It builds trust, it improves health outcomes, and most importantly, it treats the patient not just as a case, but as a whole patient.
Okay, now I will talk about a characteristic of the patient-centered approach for Parkinson's patients. The first one is individualized care. Treatment and therapy are tailored to the specific symptoms, need, and lifestyle of each Parkinson patient. Next is open communication. Encourage honest and empathetic communication between healthcare providers, patients, and family. Third one is shared decision making. Decisions about medication, physiotherapy, and lifestyle changes are made together with the patient. And is holistic perspective. Considers not only physical symptoms but also emotional, social, and spiritual aspects. Next is family and caregiver involvement. Parkinson's affects the whole household, so educating caregivers helps ensure consistent care and emotional supports. Next one is goal-oriented care. Treatment plans are based on the patient's personal goals and value, example as walking to the mosque or dancing again. Next one is continuity and coordination of care. Ensures that care is well coordinated across doctors, nurses, physiotherapists, speech therapists, and others. Last one is empowerment and education increases independence and confidence in treatments, medication timing, or mobility issues. Next, I will talk about benefits of the patient-centered care approach in Parkinson's disease. The first one is improved symptom management. Because treatment is tailored to the patient individual symptoms and priorities, motor and non-motor symptoms can be managed more effectively. The next one is better emotional and mental well-being. A patient-centered approach provides emotional support, reduce fear, and promote mental health, leading to greater hope and resilience. Next is increased adherence to treatment. When patients are part of the decision-making process, they are more likely to stick to their medication schedule and attend therapy sessions. Next is stronger support system. Family members or caregivers are included in discussions so they understand the patient's condition and can give more appropriate care at home. Next is continuity of care. The approach ensures smooth coordination between different healthcare professionals, neurologists, physiotherapists, occupational therapists, psychologists, and speech therapists. Next one is goal-driven rehabilitation. Patients set their own rehabilitation goal, such as being able to walk to the garden, hold a spoon, play with grandchildren, which keeps therapy meaningful and motivating. Next is improve overall quality of life, combining physical, emotional, and social support. Allows Parkinson's patients to maintain dignity, independence, and life satisfaction for as long as possible. The last one is support for home and daily life. Therapists help adapt the home environment, such as grab bars and non-slip flooring to reduce fall risk.
Our subjective assessment includes six components. First, demographic to gather basic patient details. Second, social and occupational history to understand the patient's lifestyle and physical demands. Third, the presenting complaint, which identify key functional issues. In this case, Mr. Lim, a 68-year-old retired electrician living with his wife in a single-story home, reports slowness in movement, stiffness, difficulty initiating gait, fatigue with minimal activity, and fear of falling. The fourth component is the history of present illness, focusing on symptom onset and progression. Fifth is the medical history, identifying comorbidities and medications that may affect physiotherapy. Lastly, we make sure to achieve the patient's personal goals. In our case, Mr. Lim's right hand tremor was noticed by his wife 3 years ago and has gradually worsened. He feels unsteady when walking but has no history of fall. He was diagnosed with Parkinson's disease in 2023. He has no other conditions and not taking any medication. His goals include walking longer, climbing stairs, turning confidently, preventing falls, and enjoying park walks with his wife. Next, we proceed with objective assessment consisting of 8 assessments. The first is static and dynamic observation focusing on posture and gait. Mr. Lim displays a stoop posture with forward head and flexed hips and knees. Gait observation reveals a shuffling pattern, reduced arm swing, freezing feet, and small steps when turning. Next, we assess range of motion to evaluate joint flexibility and mobility limitations. Mr. Lim shows reduced trunk rotation and shoulder flexion and abduction. We then assess muscle strength to identify weakness due to deconditioning. He scores grade 4 for shoulder flexors and abductors, knee flexors and extensors, but only grade 3 for hip flexors and extensors. We then assess muscle tone to detect rigidity, which is common in Parkinson patients. Mr. Lim scored grade 2 based on the modified Ashworth scale, indicating moderate rigidity. Next is the coordination assessment, evaluating motor control and smoothness through the finger to nose and heel to shin test. Mr. Lim demonstrated undershooting and jerky movements in both. Next, we perform the first functional outcome measure, the time up and go test, to assess dynamic balance and fall risk. The patient simply have to stand from a chair, walk 3 meters, make a turn, walk back, and sits down. Mr. Lim took 30 seconds to complete the TUG test, indicating a high risk of falling. The second outcome measure is 10-meter walk test used to assess walking speed and safety. Mr. Lim took 10 seconds and 25 steps to complete the distance with a step length of 0.4 meter, stride length of 0.8 meter, and gait speed of 59 meter per minute, indicating a high risk of fall. The final outcome measure is 5 times sit to stand test used to assess lower limb strength. Mr. Lim took 27 seconds to complete 5 repetitions, indicating lower limb weakness.
For interventions, we begin with education and psychosocial support, which form the foundation of patient-centered approach. We educate Mr. Lim and his wife about the progressive nature of Parkinson's, the importance of regular exercise, and key fall prevention strategies, such as installing non-slip mats and grab bars at home. We also address Mr. Lim's fear of falling through reassurance, greater exposure to functional tasks, and introducing cognitive behavioral strategies to reshape negative thoughts and build confidence. Lastly, we emphasize psychosocial support by connecting Mr. Lim to local Parkinson's community groups and involving his wife in a home based exercise program to strengthen both physical and emotional well being. Our second intervention is gait training, which aims to reduce freezing, improve step length, rhythm, and overall walking confidence. We use visual and auditory cues to enhance attention, cadence, and overcome bradykinesia. For example, stepping over colorful targets or walking according to a metronome progressively. and a normal walking speed of an adult is around 100 to 120 beats per minute. Training drills like U-turns and figure of eight patterns help reduce freezing during directional changes. We also include assisted arm swings using a stick to promote better trunk rotation and gait symmetry. Lastly, we incorporate dual task gait training such as walking while talking or counting backwards to improve cognitive motor integration, which is crucial for real-world mobility. Our third intervention is balance training, which is essential for reducing fall risks and improving postural control. We begin with static balance tasks like tandem and single leg stand to challenge balance by reducing the base of support. Then we progress to dynamic tasks such as weight shifting and functional reach, which train Mr. Lim to safely move his center of gravity within his limits of stability. We also incorporate dual task balance, like standing while counting backwards, to improve automatic postural response during multitasking, which is crucial for real life environments. This is done for 15 minutes daily, focusing on safety and gradual progression. Our fourth intervention focuses on promoting independence, safety, and confidence in daily activities. We start with rowing practice using visual and segmental cues to improve back mobility and reduce nighttime dependence. Then, stair climbing with a handrail is introduced to build lower limb strength and balance for safer stair use. Lastly, we apply compensatory strategies like using both hands or weighted utensils to manage tremor and support functional independence. Our fifth intervention is strengthening, aimed at improving postural stability and supporting functional movements. For the hips, we use seated and standing matching and bridging, targeting Mr. Lim's weaker flexors and extensors. For the shoulders, we include front raises and scaption with resistance to improve reaching and arm swing. Strengthening continues with the knees using sit to stand reps, mini squats, and teraband extension to support walking and transfers. Lastly, we train the core through trunk rotation, quadruped position, and dead bugs to enhance balance and trunk control. This program is done 3 to 5 times a week with 10 repetitions for 3 sets, lasting about 30 minutes per session. Our sixth intervention targets flexibility and postural correction to help reduce rigidity, improve upright posture, and support better breathing mechanics. We use daily stretch like seated thoracic lateral flexion and rotation, doorway pectoral stretch, and hip flexor lunges. Each hold for 20 seconds and repeat 3 times. To reinforce posture awareness, we also introduce mirror therapy, which provides visual feedback to help Mr. Lim self-correct his stoop alignment and improve body awareness during movement. Our seventh intervention targets limb coordination, fine motor control, and movement awareness, which are often affected in Parkinson's. We use bottles and finger tapping for proprioceptive training and finger to nose and heel to shin for coordination. These exercises are done 3 to 4 times a week with control repetitions to promote smoother, more accurate movement in both upper and lower limbs. Next, we have hydrotherapy, which helps reduce pressure on the joints, improve movement confidence, and builds cardiovascular endurance in a safe environment. Each session is 30 minutes, done twice a week. We start with water walking as a warm up, followed by stretching and strengthening for the arms, legs, trunk, necks, and hands, including exercises like shoulder range of motion and finger movements like playing the piano. Hydrotherapy is not essential, but is a good extra option if it's available. It can really help patients like Mr. Lim who feel unsteady on land, making exercise safer and more comfortable. Our final slide covers outcome measures and progress monitoring, which are essential to ensure our interventions remain effective and patient-centered. We use the time up and go and 10-meter walk test monthly to track mobility, gait speed, and fall risk. The 5 times sit to stand is done every 2 weeks to assess lower limb strength and functional power. And the PDQ-39, a quality of life questionnaire, is repeated every 3 months to capture changes in how Parkinson's impacts Mr. Lim's daily life. These tools help us adjust the program as needed and make sure we stay aligned with Mr. Lim's goals and priorities throughout his rehabilitation journey. That's all from our group. Thank you.